My name is Anders Perner. I'm an intensivist from Copenhagen, Denmark. I'll talk to you about the use of colloid solutions for critically ill, and I'll make the case that blood is the only colloid you need. I have a few conflicts of interests in this area. Importantly, I'm part of the Surviving Sepsis Campaign guideline group, and I was the sponsor of the Success trial, the Truth trial, and the Classic trial. So I'll, as I said, make the case against the use of IV colloid solutions for critically ill. I think the concept is not physiologic, and in clinical use, there is limited colloid effect. More importantly, no low risk of bias trials have indicated benefit from colloids in any patient population, and some colloids harm some patients. Therefore, you only need blood, and you only need that for specific indications. And for the use of IV fluids in general, there are safe and cheap alternatives in the form of crystalloid solutions. So the first question is this concept of giving intravenous colloid solutions to critically ill patients physiologic? A bit of background: the sort of natural colloid albumin is synthesized by the liver at a rate of 10 grams per day. This may be increased 3 or 2-fold in the case of loss of albumin. This equals 50 or 150, up to 150 milliliters of exogenous used albumin as 20%, as a 20% solution. However, the loss observed in critically ill is mainly to the interstitium, and the role and the kinetics of interstitial albumin is very poorly understood at presently. On this background, if you instead use a synthetic colloid, this is clearly unphysiologic. More important, let's look at the potential clinical effects of using colloid solutions in critically ill. You can do that by looking at the volume ratio between crystalloids and colloids as assessed in the clinical trials that were where the intervention was blinded to the clinical team. These are, to my knowledge, the blinded crystalloids versus colloid trials with a reasonable size, where we can assess the volume ratios observed between the crystalloid group and the colloid group, being mainly starch 130, but there's also the very large albumin trial safe there on top. These were the observed ratios between crystalloids and colloid use when clinicians blinded to the fluids gave these solutions. So there may be a slight fluid sparing effect of using a colloids, but it's minor, and in some trials it's so little that it's that these were not statistical differences between the fluid volumes. More importantly, the clinical effects, the clinical efficacy of colloids as assessed on outcomes that are important to patients and potentially important to healthcare systems with the use of a colloid solution compared to a crystalloid solution. Still, by far, the best trial on the natural colloid albumin is the SAFE trial. Large 7,000 patients randomized to either albumin use or saline use for resuscitation. Here again, showing the fluid volumes in the two groups as said given blindedly. by the clinicians on the first 4 days of the trial. There is a significant lower volume use in the albumin group, but again, the numbers are less in absolute volume. So 500 milliliters less on the first day, which then diminishes over the subsequent days. So only minor differences in fluid volumes between the two groups, even though statistically significant. The same goes for fluid balances on the first 5 days. And note here that the differences, again, 500 milliliters on the first day, sort of equals the difference in fluid input. So there is appears to be no major gain of using albumin on fluid balances, except from you give a bit less fluid. Statistically significant differences, again, on the first 3 days, but minor numerically differences. Importantly, these are the predefined outcome measures that may be important to patients and healthcare systems, and there were no differences, I may add, no differences at all in any of these outcomes between the two groups. So the albumin overall did not benefit patients or healthcare systems at least not on these measures. There was potential subgroup interaction in the SAFE trial, and this was assessed in a subsequent publication of the subgroup of patients with traumatic brain injury enrolled in SAFE. And here, worryingly, the long-term survival in patients allocated to albumin who had TBI was markedly lower compared to those who received saline, strongly indicating harm from albumin in patients with TBI. So short summary on the use of albumin in critically ill. The dosing is often supraphysiologic, meaning that most doses we would give to a critically ill patients would be much higher as compared to the normal endogenous synthesis. As you saw, there is limited fluid sparing and or fluid balances effect of the use of albumin versus crystalloids. There's no obviously benefit in patient-relevant outcomes. Harm clearly indicated in patients with TBI. There is a safe and cheaper alternative in the form of crystalloid use. Turning to the synthetic colloids, the most used and most studied also in clinical trials is hydroxyethyl starch, HES. And you probably know that the European Medicines Agency have issued a warning and strong contraindications and measures to protect patients updated a few years ago, so that the use of starch is limited in particularly in critical patients, but in all patients in general. After this issuing, there have been published at least 2 additional trials in major surgery of a reasonable size, the FLASH trial and the so-called crystalloid colloid trial. I'll just show you the important outcome measures from these 2 trials regarding the potential side effects of starch being acute kidney injury and bleeding, here as shown as the use of transfusions, and summed up in mortality. So here are the results of the 2 trials. So reasonable sized trials, close to 800 in the FLASH trial, and more than 1,000 patients enrolled in the crystalloid colloid study. you see the point estimates for all these outcomes indicate or suggests harm from the starch, both on AKI, the use of transfusion, and on mortality. To put this into perspective, I've here in the final line just show the point estimates from the trial that we did 10 years ago, the success trial done in patients with severe sepsis, showing sort of the same magnitude of harm, at least as assessed by relative risks in sepsis, as in these two new trials in major surgery. So I would think that the European Medicines Agency would reconsider the marketing authorization for the use of starch in Europe, based on these two new trial results. Gelatins, another synthetic colloid, has been used to some extent. We still have very limited safety data on this colloid. The registered side effects are identical to those of starch. So my suggestion would be to you that if you use this colloid, do so only in the context of a randomized clinical trial assessing potential benefits and harms from this synthetic colloids. So adding this up, as I said, blood is the only colloid you need. Using IV colloid solutions appear to be an unphysiologic concept from the start. In clinical practice, there appears to be very limited fluid-sparing effects of colloids versus crystalloids. No low risk of bias trial have indicated benefit in any patient population from colloid use. There are harms both from albumin and starch in some patient populations. So use blood, but again, only use this on specific indications where you need it. Crystalloids are safe and cheap alternatives to the use of colloids. With that, I would like to thank you, the IFAT organizers, for inviting me, and thank you for listening to my talks. Thank you.